So hello guys, welcome to today's class. So back with again Orthopedics Clinical Corner today, and in this session we are going to learn about examination of the wrist. So my voice is a little bit low today, suffering from cold since 2 days. Hope it doesn't disturb you. So if everything is okay, audible, visible, we shall start the class. Today we are going to discuss about the examination of the wrist and the hand. And this is also very important from the exam perspective because this malunited Colles fracture is supposed to be a very important case taking for you all. Okay, and examination. So there are not much important points to remember, only few of them. But if you remember only few of them, you would really do this case well. Okay, and then sometimes they would put spotters. So spotters usually deform the hand. So this is where our examination or the knowledge of examination of wrist and hand to play, right? So let us now understand the what are the various things which you have to learn about the examinations of wrist and hand. Okay. So these are the various things. So before, if at all you get a case of examination of wrist and hand, that means you get a case of malunited Colles fracture. Always remember that the questions will be around that Colles fracture. So they might ask you about the Smith fracture as well. They will ask you about the Barton's fracture as well. So this is what the theory you have to prepare behind. So you have to prepare the various wrist fractures, and then you have to always prepare about the forearm fractures and dislocation, right? So one joint above, one joint below, the rule, right? So in the forearm fractures, what is that which is involving the distal radioulnar joint? It is your, which fracture? It is your 𝐒𝐿𝐴𝐶𝐝 fracture. So you have to be again little bit thorough with the 𝐒𝐿𝐴𝐶𝐝 fracture. And then one joint below is your carpometacarpal joint, right? So CMC joint. So there you have to be careful. They might ask you about your Bennett's, and they might ask you about your Rolando's fracture. So this is how you have to prepare for your theory, right? So it is not in, yeah, 𝐒𝐿𝐴𝐶𝐝, very good. It is not about only about that case. So if you get a Colles fracture, no, undoubtedly they will ask you everything related to the Colles fracture. But if at all you answer these extra points, like such as you, if you answer the Smiths, the Bartons, and the extra Burnett's and Rolandos, this is a very good opportunity for you to score higher marks. Okay, and then the deformities. These deformities of the hand, usually they would be like the spotters, or sometimes they would just test your clinical knowledge, like especially your rheumatoid. So rheumatoid arthritis, it is not about the detail of that, it is about the deformities in detail you have to learn. So rheumatoid arthritis, what are the deformities you see? And then about your mallet finger, so what is mallet, what is jersey? So if at all you keep answering, they keep, increasing the questions. You have to lead the examiner towards your questions. Okay, so whatever the theory you have prepared, you have to lead them accordingly. Okay, so that is how you will score more marks. It is, so please remember, it is always not about your case, but even the theory part, if you answer well, you will get good marks. Okay, and before that, you shouldn't bluff anything, and everything. They, in any case, there would be 2 or 3 points which are very important. So if you catch hold of those 2 or 3 points, and if you are very sure about those points, then the examiner will feel that you're confident about that case. Okay, so in whenever you encounter this case of wrist and hand, especially, just assume that we have given a case of malunited Colles in your exam, and then we will continue how do we do the examination, what are the tests we are going to do, what are the movements we're going to test, and how, what is all we're going to learn today. Fine. So first, as usual, whenever there is a case, so case is, so as you see, you will get an idea of what case this is, right? So whether it is, we are dealing with the wrist, or because the case always starts with the patient pointing out with the pain, right? So he will have pain, and then he will have deformity. So what is the main important deformity you see in case of your Colles fracture? Yes. Oh, it could be a swelling which they will come up. okay, or it could be just the reduced movements, right? So they were. So what are the what is the important deformity we see in Colles fracture? Malunited Colles fracture. What is the deformity called? Yes. So this is called the dinner fork deformity, right? I know you're all well versed with it. So here we are dealing with the dinner fork deformity because it is about the Colles fracture as we have taught before, right? So these all could be your cases in case of wrist joint. So the patient can come up with pain, deformity, swelling, reduced movements. So in this history taking, you will ask the concern point. So what is that main chief complaint which the patient has come up with, right? If it is a pain, then you will ask the all the what are the characteristics of the pain. So you will ask when did it start, what was the duration of it, is it any aggravating, relieving, any associated. So this is all detailedly asked regarding the pain. And then whenever it comes to deformity, this I will tell you because this is a little bit new, right? So whenever it comes to deformity, again you have to ask about the onset. You should ask about how did it actually start, when what is the progression of that particular deformity, right? So is it progressing, is it regressing, what is happening with the deformity? And what is the main thing which you have to ask in case of deformity? It is your functional ability. What do you mean by functional ability? So functional ability, you mean what are the difficulty in doing certain activities. So what are the difficulties in daily activity, right? So daily activities difficulty level you're going to ask the patient. So patients will tell you that she is unable to do certain activities, like if it was because of the elbow joint, they might tell you about combing, turning the shirt. But if it is a wrist joint, they'll tell you about the fine movement, that they are not able to do their regular work right fastly, or they cannot cook properly because of that twisting of that spoons and all. So those are the little limited activities and fine movements about the wrist and hand they complain about, right? You have to ask those set of fine movements which they are complaining about, right? So this is about the deformity. Then swelling. I know you're all well versed with swelling. So when it comes to swelling, you know again what to ask, right? What are the things you ask? Put for swelling. You will ask again the onset. You will ask again the duration, right? Again the progression, whether the swelling is increasing in size or decreasing in size, and associated symptoms. So associated symptoms is whenever it is associated with any pain or something. That is about the swelling you ask. Then restricted movements is again will tell you about your functional limitation. So functional limitation is what are the functions they are able to do, what are the daily activities they are able to carry out, and what are the other activities which they are unable to do. This is about your general history taking. And whenever there is some history related to it, you have to, if it is something related to trauma, you have to always ask the past history related to that particular trauma. So in that particular trauma, what will you ask? You will ask what was the mechanism of injury, right? You will ask the mechanism of the injury, and then you will ask what was the treatment, initial treatment given to it. And then the very important thing you ask is your immobilization protocol. So this is called immobilization protocol. That means, was the limb completely immobilized, or when did you start? What was the treatment given to it? How long it was immobilized? So whether there was any complications associated with the treatments. So all these things you have to put together in your past, right? So this is about your history taking. So you're going to ask about your chief complaint, that is about your pain, swelling, deformity, whatever is there, right? And then you will ask the past history. In the past history especially, you have to inquire about if there is any traumatic history. If at all it is rheumatoid related, if it is rheumatoid arthritis related, then what will you ask? So if it is rheumatoid related, then you have to ask the treatment protocol. So how was the treatment started? So what is patient on specific drugs? So if there are any deformities, what are the drugs she is presently using? So all you will ask about the rheumatoid arthritis case, right? So again, you have to start with the history, So when did actually the arthritis begin? When did they diagnose? How did they diagnose the arthritis? And now what is the patient presently suffering with? So that is about the rheumatoid case. So these are the cases usually you will get, right? So one would be your malunited Colles fracture, and second one would be your rheumatoid arthritis, if at all there is any deformity which is present, right? Is that clear? This is about your history taking. So these are the important points which I'm highlighting, right? These are the important points which I'm highlighting. This you have to remember. The rest is all same. The rest is all same. Is that clear? Yes, Dhruva, can you just give a thumbs up if you're following? Okay. Now that is about your history taking. So this is about how you take the history in case of a particular case that is mostly related to your wrist. Then comes the examination. So in the examination, then we usually start with the inspection. So this is your inspection. So inspection is very, very important, because once you see, then this is how you estimate, this is how various diagnoses will set into your brain. Now you know what questions you need to ask, what to examine what to examine the patients further, right? Okay, so sometimes you may see the inspectory findings and then you go back to history and include some other points in it. So this is how you have to correlate between your history and your examination finding, right? So what is this deformity you're seeing on this screen? Yes. What is this deformity we are seeing on the screen? It is a very, very, very important and a very famous deformity, favorite of all the MBBS students. It is called the dinner fork deformity. This is a typical case of a malunited it is a typical case of the malunited Colles fracture. So what happens in a Colles fracture? So Colles fracture is nothing but it is a fracture of the distal radius that we all know. And what is the important thing we have to even know? So this is an extra articular fracture. So this is an extra of distal radius, right? Extra-articular fracture of the distal radius, and now this will result in particular displacements. This is very, very important. So whenever there is a fracture, the fragments displace. So this displacement is very important, especially in the Colles fracture, because it is a peculiar displacement which is displacing dorsally, right? So the distal fragment goes dorsally, right? And there are other displacements which you have to remember. So it might result in supination also, it is called Colles. It might result in impaction also, it is called Colles. If it is radial deviation, radial tilt, that means lateral tilt or lateral deviation is also is Colles, right? So lateral tilt, lateral displacement. Finally, very, very important, dorsal displacement and dorsal tilt, right? So these are all the things, these are all the displacements, but most importantly you have to remember it goes dorsal. So this is the dorsal movement, so it is moving up like this, the fragment moves. Now what is the most important thing in this Colles fracture? So in Colles fracture what happens is, whenever not treated properly, it will result in malunion. So what is malunion? Malunion means there will be union, but the alignment is not proper. So this will result in what is malalignment. So there will be malalignment of the fracture fragments. So whenever there is a malalignment of fragments, it will always result in the deformity, right? So this deformity is nothing but, as we explained, it is the dinner fork deformity. The dinner fork deformity. So as soon as you see this inspectory findings, what will write? You will write that this is an deformity which is present and the wrist, right? And this deformity is usually, it is showing that there is some malunion or some other growth which is usually dorsal aspect. right? So first you will write that whatever you see, that is the deformity itself. You will describe it. And then what you have to describe? To describe muscle wasting. This is very, very important in case of your inspection. So you have to talk about the muscle wasting, because in any chronic case, what we usually expect is the muscle gets wasted, right? So any chronic case, this is very, very important that we are going to talk about the muscle wasting, right? And then we are going to comment about any other swellings which are present, right? So this muscle wasting, you can even talk about the hand and the wrist together, right? So wrist and hand together. That is, it could be your thinner muscles, hyper, right? You will talk about all those things. So first you will talk about the deformity which is present, or if there are an associated swellings which are present. Then you will always conclude the inspection finding the muscle wasting, which is very, very important in case of your inspection, right? And now what is this? This is, so always remember, whenever you're talking in case of ortho, it is always better to compare. So you have to always compare with the opposite side, right? It is very, very important. So now can you tell me what deformity is this? Yes, anybody? What deformity is this? Yes, is the made lung deformity. So what is a made lung deformity? Whenever you see there is some prominence on the ulnar aspect. So this is the ulnar aspect, and you can see that the ulnar styloid process is prominent. So you will find that the ulnar styloid prominence, and then you see that wrist deviated laterally. That is what you can find out, right? So this is the deformity you will put, and this is called as manus valgus. So this is called as manus valgus. So manus is what? Wrist. Valgus is deviation, right? So this is how you will put the deformity again in case of this. So this is also one of the most like spotter case again, where if you see this is called inner fork deformity, where you see deformity on the dorsal aspect. Here you see that the ulnar styloid process prominence is there, and the wrist is deviated laterally, which is called as manus valgus. And why it is actually seen? It is actually seen because of the made lung deformity, where there is arrest in the radial growth plate, and that too in the cell aspect. So there are various theories whether this is congenital or acquired. So if it is acquired, this is of the repetitive trauma again of the epiphysis, right? The radial epiphysis, distal aspect. So then that what happens is the radial growth stops, but the ulnar growth continues, right? So this will cause outward deviation of, is called the manus valgus, and this is your made lung deformity. So this is how you describe the deformity. Again, you have to comment upon the forearm wasting, again the hand to comment. So this is about the inspectory findings. This is how you see the inspectory findings, and then you document, right? And then coming to the hand inspectory findings. So what usually we see in hand? What are the two important things which we expect? So first one, what we see is the direct spotter, which is called as the mallet finger, right? So whenever you see something like this is the flexion of the DIP, right? So this is the DIP which is into flexion. So this is called as the mallet finger. But whenever you passively do it, passively you extend it, it will go into extension. But now it is usually in the flexed position, and this is normal here. So PIP is normal, MCP is normal, wrist is normal. But what happens is this DIP cannot be extended. Why cannot be extended? What is a mallet finger? A mallet finger is rupture of the extensor tendon. So there is rupture of the extensor tendon which is attached to the tip of the distal phalanx. Base of the distal phalanx. So this is about the mallet finger. Now you can see this diagram will explain you well. So this is the distal phalanx, this is the middle phalanx. Now what happened? This is the extensor tendon which is attaching to the base of the distal phalanx. So whenever there is a tendon rupture, tendon is ruptured because of excessive flexion. Here the mechanism of the injury is excessive flexion. So now the finger goes into excessive flexion where it cannot bear, and then there will be rupture of the tendon. Right, a rupture of the extensor tendon. So it is like completely like this. So completely they go forceful excessive flexion, which will result in either the tear of the extensor tendon, or there could be a bony pull out like this. So this is called the bony finger. So this is called a bony mallet finger. So this you can only identify on the X-rays. So what is a mallet finger? A mallet finger is one where there is a loss of the extensor tendon or the tear in the extensor tendon rupture. You can also call this as the rupture of the extensor tendon. So this is a spotter again. So sometimes they can just put the picture of this and they can ask you what is this. So this is a mallet finger. You have to be very careful with the swan neck deformity, because swan neck deformity you will see there is an hyperextension here, right? But here PIP is not involved, only the DIP is involved. Okay, and then here you have one more finger which is called as the jersey finger. So this is called as the jersey finger. So what is jersey finger? Opposite to the mallet finger. So there is a rupture of the flexor tendon, right? So there is a rupture of the flexor tendon. So whenever there is a rupture of the flexor tendon, usually it is like this. But we can't say it is going into extension because our fingers are like this. But whenever there is a mallet injury, it goes into flexion, right? The rupture of the flexor tendons, and here you can see that the palmar aspect is painful. And here what happens? There is a flexor tendon which is attached to the, again, to the base of the distal phalanx here. So this is the base of the distal phalanx on the volar aspect. This is on the dorsal aspect. So dorsally it is an extensor, volar or palmar it is the flexor, right? So whenever there is damage to the flexor tendon on the palmar aspect, it will cause jersey finger. And whenever there is, so this is called the jersey finger. So the flexors are involved in jersey, the mallet, the extensor are involved in the, right? So these are the two important inspectory findings which you have to remember, or spotters in case, and especially in the hand. Now we finished the inspectory findings. Now coming to the palpation. So in the starting only I have told you that there are few important points which you have to remember whenever there is a case of examination of wrist. The first point we have covered in the inspection, that is, you talk about the deformity. So usually whenever you encounter a case of an wrist and hand, they will usually put a spotter of deformity, right? So fresh fractures usually they won't put, but they usually put the Colles fracture, and then you have to be able to tell them that this is Colles fracture. Why not it is a Smith's fracture? Why not it is a Galeazzi's fracture, right? And why not it is other fractures? If at all, they will ask you what buttons and all. So this is how you will prepare for the inspection. So inspection, you will see that you're talking about Colles. If at all it is really a Colles case, you will see that there is a displacement, or you can feel a bump which is present on the dorsal aspect, and you can see that there is a shape of the dinner fork, right? So that is, you tell it as a dinner fork deformity, right? And then palpation. So whenever it comes to palpation, you have to always confirm all the inspectory findings. So you will start the statement confirming the inspectory findings. So what are those inspectory findings you found? So you found that there was a deformity. So now how do you confirm? So to confirm it, we have certain things. So first you should always examine two things, right? So first is the radius. So you will always examine the distal end, and then ulna, distal end of the distal, yes. Then you will examine the carpal bones, right? And now, what do you examine in this? So, you will look for any tenderness, right? You will look for any irregularity, right? So, you will look for tenderness and bony irregularities in case of all these structures. So, one is your distal end of the radius and one is the distal end of and your carpal bones, right? And here, the most important thing is you have one anatomical finding, that is your radial, the bony prominence, the radial styloid process. So you will encounter whenever you're examining the distal end of the radius, rounded, right? It should and round, right? And then you will see that there is a prominence on the lateral aspect, which is called as the distal styloid process, right? So that is the radial styloid process, and the ulnar side you have the ulnar styloid process, right? So these two are very, very important bony prominences which you have to mark in case of your examination of wrist and hand. So what is the relationship between? So when we spoke about the elbow, we knew that there were three-point bony relationship, which was very, very important. Now, when it comes to wrist and hand, what is the important thing here? It is the ulnar and the radial styloid joint. So normally what happens is there is a radial styloid and now there is a ulnar styloid. But you see the radial styloid is more distal. I mean, it is more distal when compared to your ulnar styloid process. So this is the normal variant. This is normal variant. So this is here and this is here. So this appears to be more proximal. This appears to be more distal. So this appears to be more distal. That means towards the hand. So radial styloid is here. That is distal, and ulnar is more proximal. Now, whenever there is a malunited Colles fracture, what happens to this? So there is a mismatch. So now what happens is they might be at the same level or ulna may be distal, right? So normally what happens, the radial styloid is distal to ulnar styloid, right? Maybe 1 centimeter or 2 centimeters it is distal, right? So 1 centimeter, 2 centimeters distal to the ulnar styloid process. But whenever there is malunited Colles fracture, the one finding which you find is the one finding which is very, very important. Take care, you have to mark it, so this you will identify the radial styloid process. So how will you identify? You will palpate the lateral aspect of the radius, and here you will feel that there is one important bony prominence on the lateral aspect, right? So that is your radial styloid process. So the tip of the radial styloid process you will mark. And then on the ulnar side also you will come along because ulna is subcutaneous bone, you can easily palpate it, right? You will come along the lateral border of the ulna again, and then you have this bony prominence here, so you will mark. So you can see now also you can see that the radial styloid is higher when compared to the ulnar, right? This is how you will mark the point. So that is one of the important things you have to identify in case of your palpation, right? And then you obviously talk about your deformity again. So you will feel that the radius is dorsally displaced and it is rounded over there, right? And then sometimes patient may have pain, they may complain about the pain, and or ulnar styloid also you can talk if there is any pain or if there is any extra growth or something, whatever you feel in that particular case. And then in case of wrist joints, one more important thing, they might come up with the swellings, right? So this again in the inspection you will stand what type of swelling it is, but here I just wanted to make sure that sometimes it might be associated. So your case might coincidentally present with the ganglion. So this is not very, very rare, but it is most common, especially in young people, right? So what is a ganglion? A ganglion is nothing but it is a herniation, right? It is a herniation of tendon sheath covering, right? So this is an extra cystic. It is a cystic swelling of the tendon sheath or the joint capsule, right? It is an extra cystic swelling. And now you have to remember that it is usually present on the dorsal aspect. And coming to its mobility, what is the most important thing is it moves horizontally but not vertically, right? This is how you have to identify. So this is one of the most common swelling which we see in case of your dorsal aspect joint, and this is nothing but your ganglion. So ganglion is a cystic swelling which is just a outburst of the tendon sheath or synovial sheath or a joint capsule. It is filled with fluid. Now it can move horizontally, so it moves side but not up because it is along the tendon sheath, right? And then what happens is, so treatment, it could be because of any cosmetic correction, but it disappears on its own. So you can simply wait and watch, right? So treatment, if at all you want to go for treatment, then it could be an aspiration or excision, but it is usually, what we do is we wait and watch. Sometimes it disappears on its own, and for cosmetic purposes we usually they tend to remove, right? And it becomes prominent only on flexion and disappears on extension, right? So sometimes it disappears, sometimes it, right, it is like that. This is a very, very important swelling. Even though if they want to ask you anything related to the wrist swellings, the first thing they will ask you is about the ganglion. So that is why I have regarding the ganglion some few important points which they can ask, right? So that is about the swelling. So we have finished the inspection part, and then we have done the palpation. So palpation is nothing but you have to palpate all the bony structures. So first the distal end of the radius you palpate, and then the distal end of the ulna you palpate. So this is ulnar, radial styloid and ulnar styloid, and then you will see the relationship between those two. So those are the important things which you have to look for. And then you will palpate the carpal bones as well. So in case of carpal bones, so in case of carpal bones, the most important thing you have to palpate is the scaphoid bone. So scaphoid bone, and where do you palpate for the scaphoid bone? You will look for the anatomical snuff box, right? You look for the anatomical snuff box. Yes, you look for the anatomical snuff box. So when there is any, this is your anatomical snuff box. This area is your anatomical snuff. So here you will that if there is any, so this is between two tendons like that, and this is your anatomical snuff. Whenever you feel any pain or swelling or tenderness in an of box, you have to go for the x-ray, especially in the oblique view, especially in the oblique view for scaphoid. So this will have you treat the carpal bones, and again you can look for lunate. So after scaphoid, the next important bone is the lunate, and then you will look for the metacarpals as well. So how do you examine the metacarpals? So metacarpals, you palpate them along their length, and sometimes you give the axial traction to see whether there are any minute fractures. So metacarpals and phalanges, so you will palpate them along the length, and sometimes you can give axial traction to see if there is any pain or if there is any swelling, which can cause axial traction, right? So that is the important findings in case of your palpation. Then after the palpation, what is the important things you have to look for is the movement. So wrist movements. So as you all know, wrist is again your distal radioulnar, distal radius with the scaphoid lunate, right? So mainly the wrist joint is between distal radius, the distal end of the radius and the scaphoid, with some part of the lunate, and the distal radioulnar joint. So distal radioulnar joint mainly results in your supination and pronation. This is mainly for your flexion, extension, adduction, and abduction, right? So these are the movements which are usually we see in the wrist joint. This is how, this is very, very important examination of the wrist joint movement. So how do you do that? So first you will ask the patient to put two fingers or two hands like this, the Indian salutation. method which we do namaste, like we do like this, right? Namaste. So this is the position where you check the wrist joint. So now the wrist joint, and now you slowly ask the patient to elbows up. So now the elbows has to, right, and once the elbow has come, now what you see is the angle formed between your wrist, this hand and the forearm. So this is the angle you see, right? These are the angles you see. So if at all the patient is having some flexion, so which he cannot do, so usually it will be like this. It will go straight up and little down. So if you can see, this is mostly up to 90 degrees and this is right. This side it is decreased. That is how you will do the flexion and then your deflection. And this is your extension, right? So this is the flexion, extension, flexion, extension. That is abduction and adduction. So adduction is towards it, right? So this is how you have to examine for the wrist joint movement. So you will ask the patient do this position, that is the Indian salutation method, and then you ask to slightly raise the elbows. So you see that the angles between the hand and the foot, right? And then you will decide of how if is the flexion or not, right? So this is very very important movements you have to check for in case of your wrist. And now you will document. So what is the amount of wrist flexion and extension you are looking for? So either it is restricted or it is full. So usually in case of your 𝐒𝐿I's fracture malunited, you will find there is a restriction of dorsiflexion, right? So this is dorsiflexion. And see, in wrist joint again, in similarly like your ankle joint, this is dorsiflexion and this is palmar, right? So but usually whenever they say flexion, this is meaning of flexion again. Don't get confused. Flexion, this is extension. And again, please remember this is dorsiflexion and palmar, right? Understood? So, but whenever you want to comment about the movements, what we use is flexion. So, flexion is present or flexion is restricted. Extension is present or extension is restricted. So that is how we have to comment about the movements, right? And again, you have to also see for the MCP joint movement. So, metacarpophalangeal joint, right? And also the finger movement. So this is all the movements which you check for in the case of your wrist joint and your hand. So wrist and hand, you do this. So if at all they come with a deformity like this, so we have told that this is a mallet finger, right? So now you check for the movements, and not to forget, every time I mention about the movements, always document both the active movements and the passive movements, right? So similarly, in case of your mallet finger, if at all mallet finger is like this, so this is your mallet finger, so there will be flexion of the DIP I told. Now, the passive extension is possible, but active extension is not possible for the patient. And again, the PIP will be normal. So PIP he can normally do, right? Right? And MCP also normally he can do. So this is how you will do, and you will document both the active movements and the passive movements in case of your wrist joint, right? And then whenever there are certain cases, like for example, if it is a malunited case, malunited 𝐒𝐿I's fracture, and then you have done with the movements, you say that the movements are restricted, so there is so and so in this hand, and this is supposed to be restricted. And now you should always look for the special test. So in case of 𝐒𝐿I's fracture, you can encounter there could be a carpal tunnel syndrome associated with it, right? So you have to put in mind all the cases, I mean, all the possibilities which the patient can present with it. So here again, whenever you're talking about the malunited case, 𝐒𝐿I's fracture, in the history taking, again, you can ask whether it is associated symptoms, right? The deformity is associated with any other symptoms. So if at all they tell that it is associated with tingling and numbness, so this could be a carpal tunnel syndrome, so CT. So here again, whenever you put the history as CTS, you have to always conclude with a special test which is done for carpal tunnel syndrome. So what is the special test which is done? Called the Phelan's test. And then you have the Durkin's test. Right, so these are all the tests for your carpal tunnel. So patient has told you that there is tingling and numbness. This is one of the complication of your carpal tunnel syndrome. So how do you document this? So you have checked for everything, but whenever he is doing this movement, in case of wrist flexion, now he will complain that the patient on flexion, he will have symptoms. So tingling and numbness can be felt. So there will be tingling and numbness which can be felt in the thumb index, right? It can be in the thumb, the index finger especially, right? So this is nothing but your carpal tunnel syndrome. So carpal tunnel syndrome can be one of the complication of your distal malunited Colles fracture. So this is the Phalen's test. So one more test for carpal tunnel is your Durkan's test. So Durkan's test is direct compression test. This is most sensitive test and has in your NEET PG also. So this is direct compression. So what is carpal tunnel? Carpal tunnel is nothing but there is a flexor retinaculum here, no? So all the tendons will be passing there. And now what happens is whenever there is some problem in this carpal tunnel or the flexor retinaculum, what will happen is there is a compression of the median nerve which is passing through this carpal tunnel. So there will be compression of this median nerve, and this median nerve causes symptoms such as tingling and numbness in the thumb and the index finger, right? So this is how we will again try to get those symptoms into the patient by doing this maneuver, right? So this is called the proactive test, called as a provocative test. So where they will provocative means we are again asking the patient to do such a maneuver that will result in getting the symptoms. So this is how the patient usually present. And what are the complaints he will have? The complaints usually he will tell you that the patient, he will have the symptoms usually in the night time, right? And on the flexion of the wrist, on the flexion of the wrist, right? So these are all the certain symptoms you have to look for whenever you ask the history, and this is how you examine for you confirm the diagnosis. And now once you have answered them about your carpal tunnel syndrome, and then they might ask you what are the other tests or what are the other things which you can see in case of the wrist joint. So there is one more important thing is the decurvain stenosynovitis. Curvain stenovitis. Elevate with 555. Thank you so much. So much. I mean, we feel so great, whenever we hear such words. Thank you. Thank you, med student too. So now we have done with the carpal tunnel syndrome. So one that is one of the special tests which we have learned, and the second one is which is related to again the wrist joint. So now if you remember that the extensor tendons, so these extensor tendons are placed in 6 compartments, right? So they are placed in the 6 compartments. So here what happens is in case of tenosynovitis, there is a first compartment. So first compartment tendons, they get affected, and this compartment you have what? APL and EPP. So you have APL and EPP. So these are abductor pollicis longus and extensor pollicis brevis, right? So these two tendons, whenever they get inflamed, they again present you with the pain on the dorsal aspect. So how do you confirm whether this pain is because of your carpal tunnel syndrome or decurvain? Then there is a test which you can do. This is called the Finkelstein's test. So this is called the Finkelstein test, right? So what is Finkelstein's test? So Finkelstein's test is have to close this thumb into palm like this, and then you're going to form a fist. So this is how you do form a fist, and then what you do is you're going to slightly do this maneuver. So slightly you're going to ulnar deviate like, right? So towards the ulna, you're bending the wrist, right? So whenever you're doing such thing, because of that, there will be a stretch on the first extension, and then you will have pain on doing so. So this is called as the decurvain stenovitis, right? So this is one of the important thing which you have to remember, and they again will ask you questions regarding the special test also. So if you have done the movements well, and now you are going to conclude that there are no complications as such associated with your whatever you're presenting the Colles fracture case, then they will ask you what are the complications you actually expect there. So then you will tell the most important thing is you expect finger stiffness, you expect sudex osteodystrophy, you expect carpal tunnel. Then they will ask you, so what is carpal tunnel syndrome and what are the tests? How do you confirm it? So you will tell that this is the Phelan's test or the Duggan's test, which we, right? And then what are the other important things to look for? So they might ask you about decurvent stenosynovitis. So that is your Finkelstein's test. What we have to do, that is for confirm the tendons getting inflamed. So if you see the diagram itself is self-explanatory here. So there is a tendon which are covered by the tendon sheaths, right? So these tendon sheaths will get enlarged when they get inflamed. Tenosynovitis, right? Synovial layer which is present and around the tendon is called tendon sheath, and now this tendon it gets inflamed so that the movement of the tendons inside this tendon sheath is affected, right? Understood? So this is about your tenosynovitis. So that is about the special test. So we have done with the movements and then we are done with the special. Okay. So now what is this? Yes, can somebody answer what is this? This is a swelling. So till now you have done really good. So you have answered everything, whatever the examiner had asked. So he wants to test even more to give you the highest marks. So what do you think is this? So this is your compound palmar ganglion. So we have already learned that ganglion is nothing but a cystic swelling, right? Whenever something I say cystic, that means it is fluctuant and transillumination positive. These two you have to remember, right? And now I'm saying that this is a compound palmar ganglion. So what is this compound palmar ganglion? What is this compound palmar ganglion? So as the name suggests, this is compound, means something very complex thing is there inside it, and then it is palmar side. So whenever you see a swelling like this on the palmar aspect, which is again similar to your ganglion, but it is not actually looking like a ganglion, so you have to think about this compound palmar ganglion. So this is nothing but it is again a cystic like swelling which arises from your flexor retinaculum. And whenever you see this, always remember to exclude TB. So usually in case of TB arthritis, case of rheumatoid, such complex cases, they will not ask you in the exam, but I'm telling you this could be a last question. You know, you have answered everything and then they will ask you what is compound palmar ganglion. Right, so this is arising from the flexor retinaculum and usually is seen in tuberculosis and rheumatoid. Right, so this is a very big swelling. It is not like the small swelling which is present on the dorsal aspect. It is still big and it can be seen on the wrist. It can be seen and also. So this is compound palmar ganglion. Okay, and then when not to conclude your cases or not to conclude your history, and they will not leave you without asking the rheumatoid arthritis. Okay, if at all there could be a case of any deformity, if not myelinated colitis, then the case would be rheumatoid arthritis. So the two things which OPD, right? We tend to put it in exam. So what about rheumatoid arthritis? So rheumatoid arthritis, you know everything. It is an inflammatory, right? It is an inflammatory condition. Then you will put all the questions regarding the inflammatory things, and usually it is, as you know, it is an autoimmune, right? It is an autoimmune disease. And what is the most important thing? You can see polyarthralgia or polyarthritis, but again important thing, it is bilaterally symmetrical. So these are certain things which you have to put in mind, right? Whenever you're dealing with the rheumatoid arthritis, and you see there is morning stiffness. So patient will tell you that there is morning stiffness, right? And then they will usually complain. If at all in the exam, they will come with the deformity. And now you will ask all the questions relating the deformity which we have taken. So what are the things which you can see in case of your rheumatoid arthritis? So the first one is the ulnar deviation. So this is the MCP joints. Yes, very good. All those things, the swan neck, the botiniers, and you can see all the deviation to the other side. So this is the ulnar deviation. Then you can see botiniers. So what is botiniers? So botiniers is, yes, botiniers is what? Botiniers deformity is what? Where there is flexion in the PIP, right? Flexion in the PIP and extension of the TIP. And similarly, what you remember, the second one is your swan neck deformity. Swan neck is flexion in the TIP and extension of the PIP. Right? So remember F and D. So FD is your swan neck, right? Swan neck savings is FD, right? S is for savings. What you will remember? S is for your savings. And how do you save it? We usually save through the FD, which is very, very easy saving for us. There are many now. Don't get into those investments and all, but usually savings, old terminology is FD, right? We put the fixed deposit. So whenever somebody is talking about swan neck, that means flexion of the DIP, flexion of the DIP, immediately there will be extension of the PIP. So botiniers will be exactly opposite, flexion of the PIP and extension of the DIP. So that is your botiniers deformity. So we have done the ulnar deviation, botiniers, swan neck. Then what is your Z-shaped thumb? So Z-shaped thumb is again your IP will go into flexion, right? And then your metacarpal joint will go into extension and your carpometacarpal will go into flexion. So that gives a Z-shaped deformity of the thumb, right? So there is a flexion of the IP, extension of your uh, metacarpophalangeal, that is your MCP, and then your carpometacarpal will again go into flexion. So that is the Z-shaped thumb. And then your MCP dislocation. So all the metacarpophalangeal joints can go into subluxation or, so these are the various deformities which we rheumatoid, and whenever you see these deformities, they're usually like the spotter. So once you see the deformity, so there is nothing much about writing about the movements and all. So now what you do is, now the case becomes little more easy for you. So they will ask more about the theory thing. So they will ask you what is rheumatoid and how do you diagnose it. So what are the important tests you do. So CCP antibodies is now very, very important. And finally, if you're doing really well, then they will end up asking the treatment for it, right? So the treatment for it. So this is theory mainly they will ask. But for colis, they'll usually ask you about the examination points, such as your relationship between the radial stellate, then the movements, then the carpal tunnel from phalanx. That is how you have to deal with the case of the examination of wrist and the hand. Okay, is this clear? And now, once you're done with the case, then you will ask obviously for the X-ray, right? So, no case in ortho is completed without reading the X-ray. So, reading the X-ray is very, very important, and especially whenever it comes to wrist joint, because the case is little short, usually we end up landing in reading the X-rays. So, usually take PA and then we take the lateral. These are the two important things. So, wrist we take the PA and the lateral, and in the case of your wrist joint, this is how you get the X-ray. So whenever you ask the X-ray for your PA, so now just remember, usually we ask for AP, right? AP and lateral view. But in case of wrist, I'm asking PA. That means posterior anterior view. Similarly, like the chest. So usually chest, they ask you the PA view. But whenever you deal about the ribs, you want to see about the fractures, then you see AP view, right? So similarly, wrist, we usually ask the PA view so that we get a good view about all these structures. So what are the structures you see on the X-ray? We start with the radius, right? Then the ulna, you start with the radius, radial styloid, ulnar styloid, distal radio-ulnar joint. So this completes the three things. And now comes the wrist joint. So this is your wrist joint. So you're talking about the distal radius articulation with the scaphoid and the lunate. So this is distal radius with scaphoid and the lunate. And then these are your carpal bones. So these are your carpal bones which are arranged in the proximal row and the distal row. So proximal row and the distal row. This is all we know that she looks too pretty, try to catch her. Similarly, the same thing. Then you can comment on the metacarpal heads. So whenever you deal with rheumatoid, you can also comment this MCP. So carpometacarpal joint, right? Carpometacarpal joint. And then this is the X-ray. I have put this also so that whenever you will revise, it will be easy for you. So this is the, I was talking about this. So this is the proximal and this is the distal. So proximal, we start, she looks, scaphoid lunates, triquetrum, pisiform. She looks too pretty, right? And then again, try, try, trapezium, trapezoid, capitate, hamate. So try to catch her. She looks too pretty, try to catch her. She looks too pretty, try to catch. So how do you remember all these three things? So three T's we have to remember. So first is the triquetrum in the proximal row you have to remember. Then with the trap first, Z is the last one, right? Triquetrum in the proximal row, and when it comes to distal row, trapezium and the trapezoid. Trapezium and oid. Right? Remember it as M and D, MD, right? So trapezium, M, trapezoid, D. So usually, you know, whenever you are dealing with some important case, they want to test your knowledge, they will ask you to name all the carpal bones. So this you have to be little clear, okay? So proximal and the distal. So this is how you have to look for the, and then not to forget, so our important aim is to look for the distal radius as well. Here the styloid process, if you see, this is more proximal when compared to the ulnar style. So this is one thing which you see like. And again, not to forget to comment upon the distal radio-ulnar joint. Okay, that is about the AP view. Then comes the lateral view. So lateral view, what is the most important thing is, first you will comment upon the distal radius, and now you see this is your lunate, right? And this is your capitate, right? And usually this will be your third metacarpal, right? So the distal radius, the lunate, capitate, and the third metacarpal all should be in a straight line. So this is very, very important. Just remember it. Not very, very, important for you, but if you remember, it is good. So what you see on the lateral view, the radius, the lunate, you can see the shape of the lunate. Above that is the capitate and the metacarpal. So if you take a true lateral view, true matlab, it should be ekdam lateral like this. So no overlapping, not some oblique views like that. If you take a true lateral view, and then whenever you take a true lateral view, you will see something like this on the straight line. So why do you want to comment on whether it is a straight line or not? So here we are going to learn about one important thing is the lunate dislocation, the perilunate dislocation. So usually if your lunate is not in its position, lunate is not in its position like this, it has come out, then it is called as lunate dislocation, right? If the lunate is in its place, capitate and metacarpal has come out, then it is called perilunate dislocation. Very simple. If lunate comes out, lunate dislocation. Other than lunate, other carpals comes out, called as perilunate dislocation. So what are the other carpals? Your capitate. Right? So that is the lunate and perilunate dislocation. Now, if you answer this, then you will straight away they will put distinction for you, right? So this is about the lateral what you have to look for. And then you have to also look for your radial tilt, displacements on the lateral view. So usually in the AP view, what you will tell, whether this has moved like this, on the medial aspect or the lateral aspect, this. And now here you tell whether it has moved dorsal this side, palmar this side. So this is how you have to read the X-ray, right? So medial and lateral, you will talk in the AP views. Dorsal or palmars, you talk in the lateral. So this is about the X-rays which we usually discuss in the exam. Now, what is the final diagnosis? So final diagnosis is, after confirming with the X-ray and all, you will tell this is a malunited Colles fracture. So whenever you say malunited Colles fracture, duration. So it is a 2-year-old, 3-year-old. So you will tell the duration. You will tell the side, right or left side. Then with the or without the complication, right? That is how you will end up the final diagnosis. And then they will ask you what is the treatment. So if they are dealing with malunited, then they will ask you treatment. So depending upon the functional disability of the patient, you will decide whether you can treat it with the conservative, not all required treatment, but if at all you feel that this has to be treated, so then the treatment would be osteotomy. So treatment, which is called as direct osteotomy. So what is direct osteotomy? Cell ulna short. That's it. This will give you 100 by 100, full percentage. So you are going to talk about the malunited Colles fracture, right? You will tell the duration, 2 years old malunited Colles fracture of a right wrist with or without complication. The complication you will put with carpal tunnel syndrome without complication, right? And then you will tell if this is a severely impaired functional disability, you go for osteotomy, which is called as distal ulnar. I think the name is enough. You can this direct osteotomy. So whenever you want to answer for, malunion, any question they ask for treatment of malunion, just if you utter osteotomy, they will be very happy, right? Just tell osteotomy. Then they will ask you what type. Then you will tell direct osteotomy. So then, then if they'll ask you what is direct, then you can tell you will shorten the ulna. Ulna is enough for you, right? So this is how you examine the wrist examination and hand also. So sometimes in the hand they will put the claw hand that will deal in a separate class called examining the peripheral nerves, right? Thank you, doctor. So now this is our clinical corner from PW Med 2.0. You can access to any of the cases right from any clinical subject to medicine, all your minor subjects. So on the map you have to go, click on the clinical corner, then you will have all your subjects, then select ortho, then you have all the orthopedic cases like the non-union, mal to do that. Okay, so this is how we have come up with clinical corner to help you understand even the clinical knowledge also, right? I think we can conclude this for the day. Any questions? Anything you want me to ask? Any doubts you have or anything to ask? You're really welcome. We are here to answer you at any time. So you can come well. You made it as well. Do follow PW Meded and Dr. Alekhya on Instagram so that you will not miss any our offers or coming classes. So let's leave. Thank you so much. I have put this really short because these days what I've realized is I want you all to, use this as whenever you're preparing for Viva, I want to use this video because if it is short, I feel most of them will make a good use of it. So that is why I'm telling you all those important points. Want to know more? You can come back again and ask us. Okay? Thank you. Goodbye. Thank you.